No. You're good. All right. Dr. Deuk Majan here at Deuk Spine Institute. Welcome to our live stream, May 18, 2023. So our patient is someone who presents to us with back pain. And when I examined her, the pain was coming lower down at L5-S1, below her fusion. And you can see on this x-ray, Jordan, you want to show us a little bit on the x-ray? You can see she has screws and rods that were put in from a spinal fusion by a different surgeon, not me. She also has wires in there in her spine they put in to make the bone grow for the fusion. It's called an implanted or internal bone growth stimulator. Now, we're treating, show us the facet joint at L5-S1 on that picture. You guys see the joint right there? Now notice the bone is a gray, dark gray. Show us the dark gray. That whole area there, circle it, bigger, that whole area is the left L5-S1 facet joint. The reason it's gray like that when the rest of the bones are lighter is because it is thickened bone, thick bone, really thick, strong bone. And why is that? Because that joint is unstable and it's been rocking around, putting pressure on the bone. And Wolff's law, W-O-L-F-F, Wolff was a surgeon, orthopedic surgeon, who discovered that when you put bones under stress, they actually get harder and thicken. It's called sclerosis. So she has sclerotic facets at L5-S1 on the left due to abnormal stress. That's because her discs were collapsing. And now that joint is arthritic, painful, and we're going to treat it with a new treatment called the Deuk plasma rhizotomy. So we're using the x-ray machine to navigate and localize to the L5-S1 medial branch dorsal ramus using the left L5 transverse process where it connects to the pedicle. Also the S1 superior facet. So I have Jordan now helping me. Now let's take a picture. All right, that's pretty good. Show us where our target is, Jordan, on my side. That's correct, right around there. So let's see if we can get there. Shot. All right, so too low. Shot. Too medial. And that's how I do everything, is I use analyze where my tip is. It's too medial, too lateral, too high, too low. And by doing that, I can adjust my positioning. That's a little better. And I can find the right spot. So in case you haven't noticed, we use the x-ray machine to navigate. And what navigation means is we use the x-ray machine to figure out where to go and how to get there. Where to go is the target, destination, if you prefer. And how to get there is literally the path that's the best path. All right, I think that looks pretty darn good, right? Everybody agree? I feel the TP right there. So let's get ready and we'll make an incision in just a moment. And we're gonna start with our first burn. Now the Deuk plasma rhizotomy is basically a burning of the pain nerve that's located in that spot right there. And it's the same as any other rhizotomy except that we use a special tool and a technique. Tool and technique, two different things nobody else uses. They were pioneered and developed here at Deuk Spine. We're the first in the world to do it. And because of that, we're able to cure people's facet pain rather than just treat it. Sean? Most doctors only treat facet pain. We cure it. And the reason we're able to cure it is, well, simply because instead of just phasing the nerve, the pain nerve, we kill the pain nerve. We're pretty aggressive about it. Shot. Okay. So I'm just feeling around, feeling for the bone. Shot. It's real important that we're in the right spot. If you're not in the right spot, you're not going to deaden the pain nerve. You're not going to get the results you want. And you have to repeat it. We don't want to have to repeat it. Shot. I know that she is heading off to Europe soon, and she wants to get rid of this pain so she can enjoy her trip to Europe. She and I were talking before surgery. She's heading to Italy, to an area of Italy that I've been to with my son, near Milan. Shot. That's too high. Shot. That's better. That's better. Shot. Now the nerve we're deadening is called the medial branch of the dorsal ramus, and it's a pain nerve, and you really don't want it causing pain. It's horrible how much pain it can actually cause in the back. And the traditional treatments have, though they work, they don't last. And people always have to come back and have additional treatment. So what we're trying to do here is deaden this nerve in such a way that she doesn't have to keep coming back getting treatments for it. I can feel the hardware. I'm working right next to it. Okay, that should do that. So we've completed the left L5. Now we're going to go for the S1 region. No, yeah, not as much. You're right. But try that shot. All right, that looks good. So you can see the target. Show us the target, Jordan. Shot. I'm pretty close. That's the target. You guys see the little valley there in the bone? That valley is quite literally the exact spot where the nerve runs. So by using the X-ray machine, we know where the nerve is, and by burning in that area, a nice burn, we're ensuring that we're killing the nerve, the pain nerve. The problem with RFA is you may target it properly, but they don't actually kill the nerve. They just temporarily get it to stop working. We're actually going in there, and they want to permanently destroy the nerve. The goal is to permanently destroy the nerve, but they're not using the right tools to do it. Look at that. Huh? Bullseye. You like that, Luis? Bullseye. Who knows where that term came from? Anybody?
Well, I don't know, but I use it for darts.
You use it for darts, right? Anybody? I'd love to know the origin of bullseye. Anyway, Henry, do we have any questions from our audience?
Yes, we do. We have a question from Canes25 on YouTube.
Canes25, nice to hear from you today.
They ask, my great-grandpa was from the Calabria region in Italy. Have you been there? I'll have to send you a jar of my homemade canned banana peppers and oil, an old Caprese recipe.
Wow, that's wonderful. The only place in Italy I haven't been is Venice. And the reason I've been everywhere in Italy is my son is a race car driver, American race car driver. And we had to go over there and show those Italians that we can drive as Americans. And he did that. I'm very proud of him and his achievements in racing. But we've raced all over Italy. We've been all over Italy racing. And now he's our head research fellow. All right, that should be it. We got it good. I like Italy. Some areas more than others. I love visiting that country. It's one of my favorite places to visit. My wife and I went to Florence for our anniversary, about 10 years ago. All right, let's get a shot. Great. So, show us our target. I think we need to do a little bit more rotation. By the way, this entire surgery is done through a 3-millimeter incision. I think that's pretty good. Show us the transverse process. That's it. It's right there. You guys see the transverse process? Kind of nice, very easy to see. I'm going to put my incision right there, and let's see where we are. All right, so I'm too medial. I need to be more lateral. Shot. Let's see where that is. That's a little better, but too low. Shot. I think you're fine, Jordan. Too lateral. Shot. There, that's more like it. Show us the target there, Jordan. That is the target. I'm awfully close. Oh, I might be there. Let's see. Let's see where we are. Yeah, that's pretty darn good, but hold on. By the way, there's a lot of scar tissue from her prior surgery, in case you're wondering. That feels good. I'm tap dancing on top of the bone, called the transverse process. Let's just get one more shot. That's perfect. Let's show the audience, because they always ask me before you do anything. Let's show them. Come on over. Pull the fluoro out for a second and just come back to the same spot. Okay? People are asking me, how do you do the Deuk plasma rhizotomy? And we're kind of showing you about through x-ray pictures. That's the incision right there. It's tiny. It's just 3 millimeters. And the whole surgery is done through that 3 millimeter incision. You guys see that? 1, 2, 3? And we're going to do the same thing on the other side. So it starts with a needle. We want to localize the spot using the x-ray. I want to figure out what the trajectory is. We put a little bit of numbing medicine to make it more comfortable for the patient so we don't get the blood pressure fluctuations. Go ahead. And then we make an incision, and then we place our probe, the Deuk plasma spine probe. Incision. And that's really it. We just make some burns. And these burns are controlled, obviously, but they're quick, they're controlled. But I also can move my probe around because it's a stiff probe. And you want a stiff probe for this particular job. All right, let's see where we are. All right, too low. Need to be a little higher. Shot. You're going to need to come in more with your fluoro. Right? Shot. Oh, wow. What are you doing? I meant towards you. I apologize. You need to adjust your positioning. That's looking a little better, but we need to center that. There we go. Now this procedure is what we call image guided or x-ray guided, because we literally use an x-ray to guide the procedure. There we go. I can actually feel the bone now. And it's really important if you're going to do this procedure that you actually feel the transverse process with your probe, the tip of it. Because if you don't, then you could be somewhere where you're not supposed to be, which would be very bad. And then once I start my burn, it's literally a little dance. I can feel all the scar tissue from her fusion. I can feel even abnormal bone in there. And I'm dancing on the mammillary process right now. Huh? Shut? Uh-huh. I'm literally at the mammillary process, which is just at the lateral border of the pedicle. And it's right where the transverse process comes and meets with the, see, that feels like I'm above the transverse process. That feels like I'm on it. It's a little lateral though. Can feel the screw. Shot. A lot of scar tissue. Oh my gosh, so much. Feel the threads of the screw. That may be bone actually. I think it's just bone graft. Shot. See where that is. It's too lateral. So this scar tissue is now forcing me lateral. We don't want that. Shot. So you want to maintain, you can see all the calcium there, all the bone formation. You guys see the bone there? Show them the bone. That's it. Yeah, it's bone graft. That's what the other surgeon did. He did a fusion. And I'm trying to deaden the pain nerve we know that's causing all this poor woman's pain in this area. And that bone graft shot. I'm happy with the location there, but the problem is the scar tissue is literally pushing me away. There we go. But it's forcing me laterally. Let's see where that is. Hold on. Shot? It's probably a little bit lateral. Yep, it is. Shot? That's a really good spot. Shot? Yeah, it's definitely not an easy one by any means. Shot? Shot? I think that's as much as I can do right now here. Is that, I feel like the screw head is pushing me. It's interesting. Her hardware to me looks like almost like TSRH, which is a really old system. I have to look more carefully at it. That view right there makes me wonder. Shot? That's definitely, I feel the bone graft, but I want to be more medial once again. And I can't get more medial. I keep hitting something hard right there. So I'm just going to make sure we've deadened that area, which I feel I have, which I'm happy with, and then we'll move on to the S1 region. Questions?
Question from Kane25 once more on YouTube, and they asked, does this patient have a stimulator? I see wires, and those things are invasive.
Yeah, so great question. They do have a stimulator. It's called a bone growth stimulator. The surgeon put it in while they were doing their fusion. And it was put in there to help bone form, the fusion bone form. Because some people have a hard time making bone, right? Metabolically. So some surgeons will actually put a stimulator in there just to help them make bone. Yeah, we mentioned it earlier. That's perfect spot. You agree, Jordan?
Yes, sir.
Okay. Yeah, so this will be our last burn. We're done. And then we have one more case to do. Our patient next is from Austin. He's getting a 3-level bilateral L3-4-4-5-5-1 Deuk plasma rhizotomy for the same problem, by the way, facet pain. Now, he hasn't had a fusion. He doesn't need one. And here's an interesting story, the next patient, because when he came to me saying he needed disc surgery. And of course, I looked at him and I examined him. And first of all, I looked at his MRI. And the MRI had a bad disc. So at 5-1. And when he pointed to his pain during my telemed, it looked like L5-S1 is where he was pointing. Then I got him here. And sure enough, he was pointing at L5-S1. But he wasn't pointing to his disc. He was pointing to his facets. So I told him, listen, I examined him and I said, your facets are what's causing your pain, not your disc. And if I did your disc surgery, you're still going to have pain. And of course, he doesn't want to have pain. He's here to get rid of his pain. Shot? So we changed the surgical plan once he got here, and we're now going to be doing his facet joints rather than his disc. Shot? Shot? It's like this perfect spot right there. shot. That's like really where you're supposed to be. I'm just trying to get a little more medial, but I'm hitting that facet, 5-1, and it's blocking me. But I think we got it. I think I'm happy with that. All right, so let me show you the back here. She has a joint, L5-S1, just below her fusion. And you can see her screws and rods here on both sides. And that's what we're targeting, is that painful joint, arthritic joint she has. And I try to destroy the two pain nerves going to the joint, one from above, one from below. So let's hope that it worked. I expect that it did. We've not had a single failure yet. All right, any questions?
No current questions.
All right, we can end the broadcast. We'll see you back in about 30 minutes for our last surgery. Thank you. Thank you.